In the last lecture, what we did is we looked at the path that air takes to get in and out of the lungs. And we spoke very briefly about what the point of breathing would be in the first place. Now what we need to do is actually talk about what drives that air to come in and out of the lungs. Collectively, this is something that's called pulmonary ventilation, right? The actual physiological process by which the body enables air to come in and out of the lungs. We've taken a look at the passageway that it takes, but we haven't actually talked about how it gets pulled, the air gets pulled down into the lungs and then back out. And that's what we're going to do now. So to really understand pulmonary ventilation, the first thing that you have to do is understand the anatomy of what's called the chest wall. Okay, first of all, what exists inside of the chest wall? What exists inside of the chest wall is the thoracic cavity. The thoracic cavity is inside of the chest wall. Okay, what exists in the thoracic cavity? Well, the lungs exist in the thoracic cavity, and the heart exists in the thoracic cavity. But what creates the thoracic cavity? Right, a cavity is just a hollow opening inside of something, and what creates this thoracic cavity that the lungs and the heart exist within is called the chest wall. The chest wall creates the thoracic cavity. So what is the chest wall made up of? The chest wall, first of all, is made up of the rib cage. What's the rib cage made up of? The rib cage is made up of ribs and the sternum. Okay, that's the rib cage. The rib cage, the ribs, and the sternum. And additionally, the chest wall is made up of the 12 thoracic vertebrae. And finally, a variety of different muscles. Okay, the muscles that exist in between the ribs, and you can also throw this kind of dome-shaped muscle in there as well, which you're going to see is called the diaphragm. So we can summarize a little bit here. What makes up the chest wall? The chest wall is made up, first of all, of the rib cage. That consists of the ribs and the sternum. The chest wall is also made up of the 12 thoracic vertebrae. And finally, the chest wall is made up of the muscles that exist in between the ribs, and we can also include the diaphragm in there as well. That dome-shaped muscle there. Now, there are some other tissues that are also part of the chest wall, but they're not what we are going to talk about. These components that I have just gone over with you are the most important components of the chest wall itself. They're what make up the bulk of the chest wall. All right, if you look inside of the chest wall, you find a cavity, a hollow opening in the center, and we call it the thoracic cavity. The thoracic cavity exists inside of the chest wall. What does it consist of? The lungs and the heart mostly. There are other organs as well that exist within the chest wall, but they're not of our interest, at least for what we're discussing in this course. So then you say, well, why do you need to know the anatomy of the chest wall to be able to understand pulmonary ventilation, the process by which the body brings air in and out of the lungs? Why do I need to know about the chest wall? So let's keep talking about that. So this is a close-up image of a portion of the chest wall. What you're taking a look at is a portion of the rib cage, right? You're looking at the sternum, a portion of the sternum. You're looking at some of the ribs, and you're also looking at the muscles that exist in and around the ribs themselves. So that's a portion of the chest wall. And what's the relevance to this with regard to pulmonary ventilation? Well, if we take a look at some of these muscles that exist in between the ribs, it'll start to make more sense. The group of muscles that we want to take a look at right now are what are called the external intercostal muscles. The external intercostal muscles lie in between our ribs. So the external intercostal muscles are skeletal muscles, and we've established in this course that basically every skeletal muscle in the human body has what's called an origin and an insertion. Okay. A skeletal muscle is going to have a tendon that exists on each end. And one tendon is going to attach to a bone that doesn't move, called the origin, and the other tendon is going to attach to a bone that does move, which is called the insertion. So the question is, what's the origin and the insertion of the external intercostal muscles, and what's the relevance to this with regard to pulmonary ventilation? Okay, so first of all, the origin and insertion of the external intercostal muscles is a little confusing when you first hear it, but after you think about it for a couple minutes, it's not that bad of a concept. So first of all, the external intercostal muscles are always going to originate on the bottom border of an upper rib. How about we do this in black? The external intercostal muscles are always going to originate on the bottom border of an upper rib. Okay, there you can see it in black. The external intercostal muscles originate, putting an O there, on the bottom border of the upper ribs. So those are going to be the immovable bones. That's, at least in our example, going to be the specific portion of a bone that doesn't move. All right, so where is the insertion then of the external intercostal muscles? The external intercostal muscles, how about we do this in green? The external intercostal muscles are going to insert onto the upper border of the lower ribs. The external intercostal muscles, highlighted in green here, are going to insert onto the upper border of the lower ribs. They are going to insert onto the upper border of the lower ribs. So let's define the origin and insertion one time collectively. The external intercostal muscles originate on the lower border of the upper ribs, and they insert onto the upper borders of the lower ribs. Now, what will this mean for contractions? Well, if the external intercostal muscles contract, the green, the insertion, is going to move towards the black, the origin. Another way of saying that is when the external intercostal muscles contract, the upper borders of the lower ribs, the insertions, are going to move towards the lower borders of the upper ribs. One more time, when the external intercostal muscles contract, the insertion is going to move towards the origin. That means the upper borders of the lower ribs are going to move towards the lower borders of the upper ribs. And that means, if we look, that the green is going to get pulled towards the black. Okay, how about we do that with a purple arrow? Okay, the green is going to get pulled towards the black. The upper borders of the lower ribs, the insertion, are going to get pulled towards the lower borders of the upper ribs, the origin. And what is this going to result in? It's going to result in the ribs moving upwards and also outwards, like the handle on a bucket, when the external intercostal muscles contract. When the external intercostal muscles contract, the ribs collectively, in reality, what happens is the ribs move up and out. The external intercostal muscles are a hard muscle to memorize, to remember. It's just the way it is. Of all of the different skeletal muscles, I would rank the external intercostal muscles as being up there as one of the harder ones. The easiest thing to do, rather than just trying to memorize it all, is think about it functionally. Like, we know that the external intercostal muscles cause the ribs to move up and out. And that origin and insertion that I just went through with you is the only way that the external intercostal muscles would be able to do that. So beyond just trying to memorize the origin and the insertion, if you think about it, it's a much more helpful means of remembering what the external intercostal muscles do. Because again, if a muscle is going to move the ribs up and out, then that origin and insertion is the only origin and insertion that actually makes sense. Anyways, this is an image of what the external intercostal muscles do. They move the ribs up and out like lifting the handle on a bucket. This is going to become incredibly relevant for understanding pulmonary ventilation. The fact that when the external intercostal muscles contract, that they pull the ribs up and out, that is a fundamental concept for understanding how air is ultimately going to be brought from the atmosphere into your lungs, as you are going to see as we continue to progress. So now we need to talk about another skeletal muscle that makes up a portion of the chest wall, and it's called the diaphragm. The diaphragm is this flat dome-shaped muscle. And the diaphragm is a really unique muscle. It's somewhat hard to understand, just like the external intercostal muscles are. Why is that? Well, the diaphragm has technically an origin and an insertion, right? It has a bone or bones that it attaches to that don't move, called the origins. And then it has an insertion, right? Something that it attaches to that does move. But in this case, with the diaphragm, the insertion actually doesn't attach to a bone. And that's what makes the diaphragm quite unique compared to most skeletal muscles. Because most skeletal muscles, we would say that a skeletal muscle has an origin, meaning it attaches to a bone that doesn't move, and a skeletal muscle has an insertion, meaning that it attaches to a bone that does move. But that's not the case completely with the diaphragm. The diaphragm has an origin, meaning it attaches to bones that don't move. And it technically has an insertion, meaning something that it attaches to that does move. But it just so happens to be that what it attaches to is not actually a bone. Okay, let's try to explain this further. Where is the origin of the diaphragm? The diaphragm originates mostly on the lumbar vertebrae and the lower borders of the lowest ribs. You can call that the base of the rib cage, but I think the easiest way for me to think about it is, well, it's the bottom border of the lowest ribs. Anyways, that is the diaphragm's origin, the lumbar vertebrae and the lower borders of the lowest ribs. All right, then it balloons upward into a dome, and there is an insertion. The insertion is what's called the central tendon. Now, in most skeletal muscles, if we're talking about an insertion, yet again, this would be a portion of the muscle that attaches to a bone that does move when a contraction happens. And that bone would move towards the origin, the immovable bone. But that's not what happens here. The diaphragm's insertion, called the central tendon, it inserts, as you're going to see, actually onto portions of organs. And what exact effect that's going to have is a discussion that we're going to have a little bit later on. It's pretty close. So let's save it for then. You don't need to know exactly what the central tendon inserts onto to understand what's going to happen when the diaphragm contracts. Because you can look at this image and you can figure it out. Let me explain. If the diaphragm contracts, the insertion, the central tendon, is going to move towards the origin, the lumbar vertebrae and the lower borders of the lowest ribs. So what does that mean exactly? Well, just take a look. How about we do this again in purple? If the central tendon is the insertion, that's going to be, let's just say, we can't say it's a bone that can move, but we'll say that it's a portion of the muscle that attaches to something else that does move. Okay, the central tendon is going to be what moves. So during a contraction, the central tendon, the insertion, is going to move towards the origin, the lumbar vertebrae, and the lower borders of the lowest ribs. So just take a peek. What's going to happen? What's going to happen here is the diaphragm is going to flatten out. During a contraction, the diaphragm flattens. It goes from being in a dome shape to more of a flat shape. It never completely, it doesn't become entirely flat, okay, but it becomes more flat, right? The central tendon moves downwards and the diaphragm flattens out some. The central tendon, the insertion, moves towards the lumbar vertebrae and the lower borders of the lowest ribs, and thus that causes the diaphragm to flatten out to a degree. Now, the more important question to this in reality is, why does the diaphragm shorten? I mean, why does the diaphragm flatten out? Like, when a contraction happens of the diaphragm, why does the diaphragm flatten? And the answer is, well, it's because of what the central tendon attaches to. When the central tendon moves towards the lumbar vertebrae and lower borders of the lowest ribs, and it causes the diaphragm to flatten out, it's going to pull whatever is attached to the central tendon towards the lumbar vertebrae and the lower borders of the lowest ribs. So as the diaphragm flattens out, whatever is attached to the central tendon, as you're going to see, is going to move downward. Because if the diaphragm flattens out and there are organs that are perhaps attached to the central tendon, then those organs are going to be pulled downward. And in reality, it's actually something that's attached to the organs that's going to be pulled downward. It's all very complicated, and we're just not to the point of discussing it yet. The big thing that I want you to see here is just what happens to the diaphragm when it contracts, and that is it flattens out. In reality, what's going to happen is you're going to see both the external intercostal muscles and the diaphragm contract at the same time. One can contract to a greater degree versus the other, but in general, both of them contract simultaneously. They're not controlled by the same set of nerves, but with breathing, you're going to see that both of these muscles contract generally at the same time, perhaps to different intensities, but they contract at the same time. And what's that going to result in? If they both contract at the same time, you can see this. Look, here's the diaphragm. What happens when the diaphragm contracts? It flattens out. That's what's being depicted here, right? During a contraction, the diaphragm flattens out. And when the external intercostal muscles contract, what happens? The ribs move up and out. When the diaphragm contracts, it flattens out, and it's going to pull whatever is attached to the central tendon downward. And when the external intercostal muscles contract, they're going to pull the ribs up and out. And you have to think, what effect is that going to ultimately have on the thoracic cavity, right? The size of the thoracic cavity. You can see from this image that it expands the thoracic cavity. It increases the volume of the thoracic cavity itself. Because the thoracic cavity is the space that exists inside of the chest wall, which is made up of the ribs, the muscles in between the ribs, the thoracic vertebrae, the diaphragm, and perhaps if the external intercostal muscles and the diaphragm both contract, and the diaphragm flattens out and the external intercostal muscles cause the ribs to move up and out, that's going to expand the volume of the thoracic cavity, the size of the thoracic cavity. And then you might think, well, that is for the purpose of allowing for the lungs to expand, perhaps, when we're breathing. And you would be right. But why this causes, perhaps, the lungs to expand is an entirely different conversation that is much, much more complicated than you would ever think. So to fully understand pulmonary ventilation, the process by which air comes in and out of the lungs, you first of all, of course, need to understand the anatomy of the respiratory system. You also need to understand what the external intercostal muscles and the diaphragm does when it contracts. And then additionally, you need to understand these serous membranes. Okay, what are serous membranes? Serous membranes are membranes that exist around most of our internal organs. Okay? Serous membranes exist around the heart, they exist around the lungs, they exist around most of our intestinal organs. Obviously, we're going to be focused on the lungs, but I'm just pointing out that you learn in anatomy that they exist around most of our internal organs. And the challenge is actually understanding their structure. That is the part that people really struggle with. And it's incredibly important to understand their structure if you actually want to understand how the lungs work during breathing. It's maybe the most important thing, actually, is to understand the organization of the serous membranes. So I'm going to do my best. To start off with, your book does a good job of this, I think. What the serous membranes actually are, to start off with, to call them membranes is a little bit deceiving because it's actually the whole membrane is continuous with one another, and you kind of end up with two different layers. But the serous membrane actually starts off as kind of like one membrane. And to imagine this, what your textbook talks about, and it does, again, as I said, a nice job of this. Imagine the serous membranes. They start off as basically a deflated sac. And by that I mean, imagine this, what the textbook does is it says, imagine the serous membranes as a heavily deflated but closed balloon. One serous membrane, for example, that would surround the heart or that would surround the lung. One serous membrane would be one of these sacs, small sacs. And they're not always small, but get rid of that word small. One serous membrane would be like a deflated sac. Some are large and some are small. Depends upon the organ that they surround. But imagine a serous membrane as a deflated sac. Better yet, imagine a serous membrane as a heavily deflated and closed balloon. That's what is depicted actually in this image. This right here would be a heavily deflated, there's some air in the balloon, but it is a heavily deflated but closed balloon. That is what you have to imagine because structurally it's almost identical. Structurally it's almost identical. A serous membrane would be like a heavily deflated and closed balloon. Structurally, that's what a serous membrane is like. Now to imagine how the serous membrane is organized actually around an organ, that's a completely different conversation. So yet again, we're imagining that this serous membrane that we're about to discuss here, because we want to understand it structurally and how it exists around an organ. Imagine that this serous membrane is a heavily deflated balloon, right? The balloon is closed, but it's heavily deflated. Now, since we're focused on the lungs, here's the next thing that you need to imagine. Imagine that you take a lung and you push the lung into this heavily deflated balloon. Again, we're pretending that this deflated balloon is actually a serous membrane because structurally, yet again, they're pretty much identical. It's just an analogy to try to help understand their organization. So now what you do is you take the lung. Your textbook has you imagine it as your fist, but we're just going to bypass the fist and we're just going to imagine the lung. So you take the lung and then you dunk the lung into this heavily deflated balloon. Okay. And again, that heavily deflated balloon is the serous membrane. Okay. Structurally, they're the same, so we're pretending that the balloon is the serous membrane. You're taking the lung and you're dunking it into this deflated balloon. And when I say into the balloon, there's a very important distinction to make here. I don't literally mean inside of the balloon. The balloon is closed. You're not taking the lung and pushing it inside of the balloon. That's not what I mean. Okay? The balloon is closed. You're taking the lung and you're pushing the lung into, or let's say onto, this deflated balloon. That's a better word. You're pushing the lung onto this deflated balloon until the deflated balloon conforms around the lung. In this case, it's showing somebody's fist, but imagine instead of the fist, there's a lung there. Okay, the deflated balloon would conform around the lung as you push the lung onto the deflated balloon. I don't want to use the word into, although technically you could, but I just want to make sure that you understand. I don't literally mean that the lung is going inside of the balloon. You're pushing the lung onto this deflated balloon, on the top of it, until the deflated balloon, which is very deflated, so since it's so deflated, it can begin to conform around the lung itself. What you would end up with is technically kind of two different layers of the balloon. You would have a layer of the balloon that would actually be making contact with the lung, right? Since the balloon has conformed around the lung, there would be a portion of the balloon that would actually be making contact with the lung, physically touching the lung. And then there would be a layer that would not be physically touching the balloon. We're going to talk about the actual terms, but those are kind of the two different layers of these membranes. Okay, there's going to be a portion of the membrane that actually makes contact with the organ. Oops, that was supposed to be in black. That actually makes contact with the organ, physical contact with the organ. And then there's a portion of the membranes, in this case the balloon, that doesn't actually make physical contact with the organ. Okay. Now, there's going to be something that exists between these two kind of layers, membranes as well. In this case, it's a balloon, right? So what would exist between these two layers in black and green? There would be air in there. That's what's literally inside of the balloon. There would be air in there. This is how the serous membranes are organized. It would be like taking an organ and pushing it onto a heavily deflated balloon until the balloon conformed around the organ. That is how the serous membranes are organized. There would then be a portion of the serous membranes that would actually make physical contact with the organ. There would be a portion of the serous membranes that wouldn't make physical contact with the organ. And then between those two layers, those two membranes, there would be space that would exist. In the case of a balloon, there would be air in there. Okay. In the case of the actual serous membranes, there's not air in there, there's actually water, a fluid that exists in there. So now let's go through the actual correct terminology. All right, so we're going to talk about this for real this time. You've got the lung, you've got a lung inside of the human body. Okay? The left lung, the right lung. Imagine one of them. And then what you imagine doing is imagine taking one of the lungs and pushing it into this heavily deflated sac, which is a serous membrane. That heavily deflated sac, which is a serous membrane, would conform around the lung. And you would end up with a layer of the sac that is making physical contact with the organ in black. And then you would have a portion of the sac, the membrane, that does not make physical contact with the organ in green. Okay. The portion of the sac, the serous membrane, that makes contact with the actual organ itself is called the visceral serosa. Okay, that should be in black for consistency. The visceral serosa is the portion of the serous membrane that actually makes physical contact with the organ. It's touching it. And the portion of the serous membrane that does not make contact with the organ, that's like the portion of the balloon in our example that does not make contact with the organ, is referred to as the parietal serosa. That's what would be in green. So you've got the lung pushed into this deflated sac that has conformed around the lung. The portion of the sac, some people would refer to it as a layer, but you can't really call these layers because, as you can tell, they're continuous with each other, so they're not really layers, but some people think about them as layers. The layer, the portion of the serous membrane that's making physical contact with the organ is the visceral serosa in black. And the portion of the serous membrane, sometimes thought of as kind of the outer layer, although again, it's not really a layer, is called the parietal serosa. Okay. And then again, what exists between the visceral serosa and parietal serosa? Again, a serous membrane is like a sac. It's like a deflated balloon. So what would exist between the visceral serosa and parietal serosa would be space. It would be the space that exists inside of the balloon, inside of the sac. And we refer to that as the serous cavity. Now, if this were a balloon, like we've been giving an example of, there would be air in there. But in the case of the human body, what exists in the serous cavity, the space between the visceral serosa and parietal serosa, is actually what's called serous fluid. It's mostly water. That is how the serous membranes are organized. Okay? And let me tell you something else. In the human body, let's erase the blue. The visceral and parietal serosa are very, very close to each other in distance. Okay? They're so close to each other that they basically are making physical contact with one another. If you were to see them underneath it, you'd have to look at underneath a microscope to be able to tell that the visceral and parietal serosa actually aren't physically attached to each other. Okay? But nonetheless, they're not physically attached to each other, and there is a space that exists between the visceral and parietal serosa because, again, structurally, the serous membrane is like a balloon. It's like pushing the organ into a deflated balloon until the deflated balloon conforms around it. And between the visceral and parietal serosa, there would be a space in there. And there is a space in there called the serous cavity, and it's filled with a fluid, with water, and that's called serous fluid. There's some exceptions to this rule, but let's say this. Most of the internal organs in our body they exist within these serous membranes. The heart exists within a serous membrane. The lungs do. The liver does. The intestines do. They exist within these actual serous membranes. And to imagine any one of them, all you have to do is imagine the serous membrane as just a deflated sac, just like a heavily deflated balloon. And then imagine taking an organ like the heart and pushing it onto that deflated sac, that serous membrane, until that deflated sac, also known as a serous membrane, conforms around the organ. And at that point, you would have a portion of the serous membrane, the sac, making contact with the organ called the visceral serosa. You would have a portion of the membrane or the sac not making contact with the organ called the parietal serosa, and then you would have a space in between the visceral and parietal serosa, which is a cavity that's filled with fluid. Now, what you learn about in anatomy, or what you learn in anatomy, is that these membranes are important for reducing friction that an organ experiences as it moves around internally. Basically, the serous fluid helps reduce the amount of friction that the organ would experience as it rubs against other structures in the human body. And that's absolutely true, but there's much more to the overall functionality of the serous membrane when it comes to the lungs. So here you can see the left and right lung, and you can actually see that each has their own respective serous membrane. Okay. The lungs in many ways are kind of mutually exclusive from each other. You can basically lose your left lung and still have a functioning right lung. And even the lobes are pretty remarkably separated from each other as well. So the point I'm trying to make is, without going off on too much of a tangent, is that each lung has its own serous membrane. And that's what's clearly being depicted in this image. The serous membranes are depicted in blue. Okay, so what you have to imagine is just pick a lung. Okay, we'll pick the left lung. Take the lung, and then you have this serous membrane, which is a deflated sac. And then what you do is you push the lung onto this deflated sac until this deflated sac, which is a serous membrane, conforms around the lung. And as that sac conformed around the lung, you would end up with a portion of the sac that would be making contact. I'll draw it I can't do the whole thing because I think it would look, well, maybe I can. You would end up with a portion of the sac that would be making direct contact with the lung. Sometimes kind of thought of as the inner layer, but again, call these layers is a bit of a stretch. The portion of the membrane, the portion of the sac that's making physical contact with the lung would be referred to as the visceral serosa. Now you're about to see we're going to exchange the term serosa for something else when we're talking about the lung, but that's what that layer in black would be. Okay, now where would the parietal serosa be? The portion of the sac, the portion of the membrane that doesn't make contact with the lung. It would be right here. Well, let's pick a different color, red. Be right here. That is where the parietal serosa would be. Let's erase this. Okay? That's where the parietal serosa would be in black. The portion of the sac, the portion of the membrane that does not make contact with the lung. What exists between the visceral serosa in black, making contact with the lung, and the parietal serosa in red, not making contact with the lung? Yet again, parietal serosa sometimes thought of as the outer layer, but you know that I don't like the term layer. So anyways, what exists between this visceral serosa and parietal serosa? Well, there's space in between there. We'll draw it in blue. Well, how about a different blue? There's space that exists in between there that I'm drawing in blue, and that would be called the serous cavity. What exists within the serous cavity in blue? Fluid that we call serous fluid. And you'll notice this exact same organization exists on the right side too. The right lung is dipped into its own serous membrane, its own deflated sac, until we find in kind of an inner layer, right? A portion of the membrane, the sac that makes contact with the lung, called the visceral serosa, and an outer layer, a portion of the sac, a portion of the membrane that doesn't make contact with the lung, called the parietal serosa. Space in between, called the serous cavity, filled with serous fluid. And I do want to point out, if you'll notice, as you dip the lung into this deflated sac, this serous membrane, the serous membrane, doesn't end up fully encompassing the lung itself, right? There's a gap between the two ends, if you look, right? There's a gap between the two ends. And why is that there? Well, because that is where ultimately the primary bronchi, or in this case, since we're talking about one, this is where the left primary bronchus enters into the lung. So now I'm about to throw a bit of a terminology curveball at you, but it's very necessary ultimately to make sure that the terminology is right in order to be able to do the rest of this lecture. So this image is showing you exactly what we've been talking about. It's showing you the left and the right lung within a serous membrane, a deflated sac, just like the last image. There's a portion of that membrane or sac that makes direct contact with the lung, which we could call the visceral serosa. And there's a portion of that membrane or sac that doesn't make direct contact with the lung. We could call that the parietal serosa. Space in between would be the serous cavity filled with serous fluid. Okay, what's the point of this? Okay. The point is, well, the names actually get changed a little bit when you're talking about specific organs. Here's what you do. When you have a serous membrane that exists around the lung, one lung, or the lungs, whatever, you take the generic term serosa or serous, and you swap it out for the term pleura or pleural. That actually implies a specific serous membrane to the lungs, a serous membrane that is specific to the lungs. Let me again explain here. So right here, right, that's the lung. And in black, I've highlighted what would usually be thought of as the visceral serosa, right? That's the portion of the sac or the membrane that makes direct contact with the lung. But since this is a serous membrane that is specific to the lung, what we do is we take the word serosa and we exchange it for the word pleura. So instead of calling it the visceral serosa, which is what it is, by the way, we call it the visceral pleura. The visceral pleura is the visceral serosa. It's the portion of the membrane or the sac that makes direct contact with the organ. In this case, since it's the lung, we call it pleura instead of serosa. Okay, out here in green. In green, that's the portion of the sac or the membrane that doesn't make direct contact with the organ, in this case the lung. We would usually call that the parietal serosa generically, but since this is specific to the lung, since it's a serous membrane that is specific to the lung, instead of calling it the parietal serosa, we call it the parietal pleura. Parietal pleura is parietal serosa. It's just a specific serosa that a specific serosa to the lung. So instead of calling it parietal serosa, we call it parietal pleura. All right, and then you can probably imagine the space in between would usually be called the serous cavity. But instead of calling it the serous cavity, since it's specific to the lungs, we call it the pleural cavity. And what's usually in the serous cavity, which is now the pleural cavity, since it's specific to the lungs, there's usually serous fluid in there. But what do you think we call it instead? You take the word serous and you exchange it for pleural, so you would call it pleural fluid. Okay. So let's wrap this up one time. This is very important, by the way. When we talk about the serous membranes specific to the lungs, here's what we do. We call the visceral serosa the visceral pleura. The portion of the membrane or sac that makes direct contact with the lung is called the visceral pleura instead of the visceral serosa, even though they're synonymous. They're the same thing. And the portion of the membrane or sac that does not make direct contact with the lung is called the parietal pleura instead of parietal serosa, means the exact same thing. The space that exists between the visceral and parietal pleura is referred to as the pleural cavity instead of serous cavity, and the fluid that is in there is referred to as the pleural fluid instead of serous fluid. It's all exactly the same thing. It's just that these are serous membranes that are specific to the lungs. So we use a term that is pleural or pleura instead of serous or serosa. So if I've still failed you up to this point, here is one more image of the same thing, trying to show you the different portions of the serous membrane, the different layers, if you will. Yet again, although I don't love the term layers, but this is what it's showing you. Imagine, again, taking a lung and dipping it into a deflated sac, which is a serous membrane, until it conforms around the lung. And then you would end up with a portion of the sac that would be making direct contact with the lung, called the visceral pleura, and you would be making, then a portion of the membrane or the sac would not be making direct contact with the lung. That would be called the parietal pleura. And then there would be space that would exist between the two, which I'm drawing in blue there, which would be the pleural cavity filled with pleural fluid. It has not been a mistake on my end that I've been going through this so many times, even more than I normally do with things. It's because this is, understanding this structure is so important to understanding how the lungs work. It might, for the average person, even somebody that's taken anatomy and some physiology before even, this might seem initially kind of silly to be talking about. Like, what is the relevance of this to the physiological explanation as to how air gets in and out of the lungs? But the answer is this anatomical organization of the serous membrane with relationship to the left and right lung, there's almost nothing that's more important, as you are about to see here. So let me begin the process of trying to explain why the pleural membrane ultimately is so important to the lungs. What you're looking at here is a portion, a small portion of the chest wall, right? You can see two ribs here. You can see the intercostal muscles that exist in between the ribs. And then you can also see the skin and the hypodermis here as well that lies superficial or on top of the ribs and intercostal muscles. Right? That's a portion of the chest wall. Small portion of it, but nonetheless, that's a part of the chest wall. Now, what lies deep or underneath the chest wall? Okay. Deep or underneath the chest wall is where you find the thoracic cavity. And what's inside of the thoracic cavity? Well, the lungs. This is a portion of one lung that lies underneath or deep to the chest wall. So you can clearly see here, and this should make sense, the lung and the chest wall butt up right next to one another because, well, the lung literally exists in the thoracic cavity that's created by the chest wall. So they are right next to each other. Now, the most important part of this is to see the pleural membrane here. You can see the two different parts to the pleural membrane. You can see right here, we'll draw it in black, that is the visceral pleura. That's the portion of the pleural membrane, this deflated sac that makes physical contact with the lung. And then you can see, let's draw it in green, the parietal pleura. That's the portion of the pleural membrane or this deflated sac that doesn't make physical contact with the lung. And then in between them, in between the visceral and parietal pleura, we'll have to draw that in a different color. How about red? there is the pleural cavity filled with pleural fluid. So what's the relevance of showing this image? The relevance of showing this image is to show you that the parietal pleura actually adheres to, attaches to, the inside of the chest wall. Do you see this here? Yet again, let's erase this all. This right here is a portion of the chest wall. We know that underneath or deep to the chest wall is where the lungs are. And we know that the lungs are kind of immersed and surrounded by this pleural membrane, okay, on the lung surface. And there's two parts to the membrane. There is the visceral pleura that makes direct contact with the lung. And then there is the parietal pleura, which doesn't make direct contact with the lung. And that parietal pleura lies closer to the inside of the chest wall, and it actually physically attaches to it. This should make sense anatomically. We can look at this in a different way to try to drive the point home more. So here is the chest wall again, okay, and showing the lungs within or deep to the chest wall. What do you see? The right side is fully intact. And on the left side, what's happened here is a portion of the chest wall has been removed. The kind of the anterior front half of the chest wall has been cross-cut and extracted. So you're actually able to physically look at the lung, the left lung. And you're seeing that the left lung is encased in this deflated sac that is the pleural membrane. Now, most of the anterior half of the pleural membrane has been removed as well, so that you're actually seeing the true lung itself. But this right here is the pleural membrane, what I'm drawing in black. Okay. So that portion of the pleural membrane is still intact. And what this image is actually trying to show you is the relationship of the pleural membrane to the chest wall. On the left side, enough of the pleural membrane has been left intact to be able to show you the relationship of the pleural membrane to the chest wall itself. And this is what you see. You know that the lungs exist in the thoracic cavity, which is created by the chest wall. The thoracic cavity is deep or inside of the chest wall itself. So just like the previous image, we know that the lungs lie right underneath or right deep to the chest wall itself. Here over on the right, you can see, right, there is a portion of the chest wall. You can see a rib, you can see the intercostal muscles. And then right underneath the chest wall, right deep to the chest wall, is where the lung is. So here we go, right, in black, there's the chest wall. Right, that's a part of it that's been cross-cut, but it's allowing you to see, since it's been cross-cut, it's allowing you to see the true relationship of the chest wall and the lung. And right underneath the chest wall, you can draw it in red, right, there's the lung. Okay. The lung butts up right underneath where the chest wall is. Right? It's right deep to it. Okay, so what's the lung covered in? Right? It's kind of immersed and surrounded by this deflated sac that is the pleural membrane. And there are two parts to it. Right? Right here in black, that is the visceral pleura. And then in green is the parietal pleura. Visceral pleura is the portion of the pleural membrane that makes direct contact with the lung. Parietal pleura is the portion of the pleural membrane that does not make direct contact with the lung. In between the two is the pleural cavity filled, how about in red, with pleural fluid. But the point of this is to show you that the parietal pleura, and you can see it again in this image, the parietal pleura actually makes physical contact and attaches to the inside of the chest wall. Yet again, I'm drawing the chest wall, I'm highlighting it in black, and you can see that the parietal pleura, right, the sort of outer layer of the pleural membrane, some people would like to say, the portion of the pleural membrane that does not make physical contact with the lung, highlighted in green, I'll do it again, actually physically adheres to the inside of the chest wall itself. This is true throughout the entire left and right lung. All throughout the left and right lung and the left and right portion of the chest wall. Everywhere here. Front and back side, anterior and posterior side. The parietal pleura adheres to or attaches to the inside of the chest wall itself. It's attached to it. Incredibly important thing to know for what's coming. Next, here's the diaphragm. That dome-shaped flat muscle. Okay. Here's where the central tendon would be. I can highlight that in green actually. Right, this is where the central tendon is located. And remember, the central tendon is technically the insertion. Although remember, the central tendon, this tendon doesn't actually insert onto a bone. What does it actually insert onto? Well, take a look. The parietal pleura that exists around the base of the lung, the left and right lung, actually attaches to the upper side of the diaphragm. So all throughout here, I'm drawing it in black, the parietal pleura attaches to the inside of the chest wall, right? And then the portion of the parietal pleura that exists around the base, that means the bottom of the lung, that portion of the parietal pleura actually physically attaches to the diaphragm itself. And then you can also see what's called the pericardium, this fibrous sac that exists around the heart, which is actually made up of serous membranes as well, mostly. It also attaches to the diaphragm. So really the correct thing to say about the diaphragm is it actually inserts onto the membranes that surround the lungs and the heart. So perhaps you can begin to think about what happens if the diaphragm contracts and flattens out. Because if the diaphragm contracts, the insertion, which is the central tendon, is going to move towards the origin, which is the lumbar vertebrae and the bottom borders of the lowest ribs. And that's going to cause the diaphragm to flatten out. And if the diaphragm flattens out, what's it going to do? It's going to pull these membranes, these, the parietal pleura, as well as the membranes that surround the heart, downward. And perhaps you can already think about this. If the chest wall moves up and out due to contraction of the external intercostal muscles, what effect is that going to have? Perhaps on the parietal pleura that adheres to the inside of the chest wall, which is now moving up and out. So now we're starting to get real close to talking about how pulmonary ventilation, the process of bringing air in and out of the lungs, actually happens. You have, hopefully, it makes sense, most of the kind of anatomical concepts that we've gone through. And with those concepts, you can really begin the process of understanding how the lungs get air in and out of them, how you get air in and out of your lungs. How does the body accomplish this? So before we can really begin to discuss that concept, there's sort of one last thing that we need to go over. And that last concept is discussing air pressures. All right, so what is air pressure? First of all, what is air made up of? Air is made up of gases. Okay? As you're going to see when we get to gas exchange, the air is made up of approximately 21% oxygen gas and 79% nitrogen gas, and then some other very small quantities of other gas molecules are located in there as well. That's not the point of the conversation for the moment. It's just to acknowledge that air is made up of gas molecules. So what is air pressure? It is literally the pressure that the air ultimately generates. Blood pressure is the pressure or force that the blood exerts against the wall of a vessel. Air pressure is quite literally the amount of pressure or force that the air is creating within the atmosphere itself. Now, to understand what that actually means, you have to understand what air is made up of, which is gas molecules. So air pressure ultimately comes down to how tightly compacted these gas molecules are. If these gas molecules are very tightly compacted around one another, then they create lots of air pressure. If they're very loosely compacted around one another, meaning they're not very well compacted around one another, they don't tend to create lots of air pressure. So just keep that in mind. And now we'll move on to, first of all, talking about what's called atmospheric pressure. Atmospheric air pressure. That is the pressure that the air creates in the atmosphere at sea level. Now, this might seem kind of arbitrary, but we can very easily measure this. It's around 760 millimeters of mercury. That is standard atmospheric air pressure at sea level. Saying at sea level is pretty important. If you're in Miami, you're pretty much at sea level. And that is kind of the reference point. In Gainesville, we're a couple hundred feet above sea level, but that really doesn't have that big of an effect. Now, if we were a couple thousand feet above sea level, it would start to have an effect. But generally, most of Florida is very close to being at sea level. So you can take this term or this value to be quite literal here. The standard air pressure at sea level is around 760 millimeters of mercury. Okay, what's this next one? Intra-alveolar pressure. That means the air pressure essentially within the lungs. What it really means is the air pressure within the alveoli themselves, which is inside of the lungs. And in between breaths, the intra-alveolar pressure, meaning the air pressure within the lungs, is actually the same as atmospheric air pressure. It's about 760 millimeters of mercury. So the air pressure in the atmosphere and the air pressure in your lungs, at least in between breaths, is exactly the same. Yet again, this is the pressure or force that the air is exerting based upon how tightly compacted these gas molecules are with one another. And the air pressure in the atmosphere and the air pressure within the alveoli, kind of at rest in between a breath, it's exactly the same. Next, this is where things get a little different. Intrapleural pressure. What does that actually mean? What it means, for all intents and purposes, this is a little bit more confusing than this in reality, but intrapleural pressure means what is the pressure that exists inside of the pleural cavity. Remember, the pleural cavity is the space that exists between the visceral and parietal pleura, right? This is the pleural cavity in blue here, right? The space that exists between the visceral and parietal pleura. And when we say intrapleural pressure, we say, what we mean is, what's the pressure within the pleural cavity? Intrapleural pressure. Now, the reason I keep saying pressure and not air pressure is because I've discussed what's actually in the pleural cavity is fluid. So it wouldn't technically be accurate to say air pressure within the pleural cavity. But for the sake of this conversation and for the sake of simplifying things, we're going to pretend that inside of the pleural cavity, there's air, and this is air pressure. Okay? It just makes things easier to understand, because conceptually it means the exact same thing as talking about the pressure that exists within a fluid, okay? The pressure that the fluid is exerting. Yet again, to make things easier, we're going to say, what is intrapleural pressure? We're going to say that it is the air pressure within the pleural cavity. Again, it's really the kind of fluid pressure, but it means conceptually the same thing. So what is atmospheric pressure? The air pressure in the atmosphere. 760 millimeters of mercury. We can measure that. What is intra-alveolar pressure? The air pressure of the air that exists inside of the lungs, in the alveoli. It's 760 millimeters of mercury. And then you say, what's intrapleural pressure? The air pressure, the pressure of the air inside of the pleural cavity. Again, it's fluid, but we're pretending it's air. What I can tell you, I'm not going to explain it quite yet, is that intrapleural pressure is different than either atmospheric pressure or intra-alveolar pressure. It's not the same. The pressure of the air, quote unquote, which is actually fluid, inside of the pleural cavity is not the same as the air pressure in the lungs, intra-alveolar pressure, or the air pressure in the atmosphere, atmospheric pressure. And then lastly, this term, transpulmonary pressure. Transpulmonary pressure is the difference between intra-alveolar pressure, meaning the air pressure in the lungs, and intrapleural pressure, meaning the pressure, we're calling it air pressure in the pleural cavity. This one also is hard to explain the meaning of without more context. So that's what we're going to do now. So what we want to do here is try to understand pleural pressure. We're pretending the air pressure inside of the pleural cavity. And to understand where pleural pressure is coming from and its relationship to intra-alveolar pressure and atmospheric pressure, you have to understand a couple things, and that is that the lungs are incredibly elastic and constantly recoiling inward. Basically, the lungs are always wanting to collapse in on themselves. And the chest wall is elastic, but in the opposite direction. The chest wall is constantly wanting to expand outward. Okay? And this is a constant tug of war where the lungs are trying to recoil and collapse inward, and the chest wall is trying to expand outward. And then you think, well, what overall effect is this having? Well, what attaches to the lung itself? The visceral pleura. In black here, the visceral pleura actually attaches to the lung. And then what attaches to the inside of the chest wall? In green, the parietal pleura. So the point here is, well, if the lungs are constantly trying to recoil and collapse inward, and the chest wall is constantly trying to expand outward, just due to their natural elastic traits, what is that going to do? It's going to pull the visceral and parietal pleura away from one another, right? Because of the fact that the lungs are always trying to collapse inward, that pulls the visceral pleura that attaches to the lungs inward. Right? It's pulling the visceral pleura that attaches to the lungs inward. And the parietal pleura, on the other hand, is constantly being pulled outward, right? Because the parietal pleura attaches to the inside of the chest wall. And the chest wall is constantly trying to expand outward, which is pulling the parietal pleura outward, because the parietal pleura attaches to the inside of the chest wall. And if the chest wall is constantly trying to expand outward, it's going to be pulling the parietal pleura outward. So these two membranes, in reality it's one membrane, but let's just say the two portions of the pleural membrane, the visceral pleura and parietal pleura, are being pulled away from each other. So this is an image from your text which is showing the same thing. What's happening here is this is the chest wall right here. Here is the lung, right? So what attaches to the inside of the chest wall? For consistency, we'll draw it in green. That is the parietal pleura. What attaches to the lung? We'll draw it in black for consistency. That is the visceral pleura. What is the chest wall constantly trying to do? Expand outward. What is the lung constantly trying to do? Recoil or collapse inward. What effect does this have? Well, it pulls the parietal and visceral pleura away from each other, right? As the chest wall expands outward, it pulls the parietal pleura in green outward, because the parietal pleura attaches to the inside of the chest wall. As the lung collapses or recoils inward, it pulls the visceral pleura in black inward, because the visceral pleura is attached to the lung itself. So the parietal and visceral pleura are constantly being pulled away from each other. And what that does is it causes the volume of the pleural cavity to expand, to become larger, right? If you think about it, here is initially up here, right? There is the parietal and visceral pleura. And then the two of them are being pulled apart. The chest wall is pulling the parietal pleura outward. The lung is pulling the visceral pleura inward. And as that happens, as they're being pulled away from each other, the volume of the pleural cavity expands, because these two membranes, again, really one membrane, but we can think of them as being two different membranes, are being pulled away from each other. And by pulling them away from each other, due to the chest wall expanding outward and the lungs collapsing inward, you expand the size or the volume of the pleural cavity itself. And what effect would that have on air pressure is the question. Okay, we're pretending that the pleural cavity is filled with air. Okay. To start off with, the volume of the pleural cavity would be smaller. That would cause the air to be more tightly compacted. And what would that do to the air pressure? Well, of course, it would drive the air pressure in the pleural cavity up. Okay. Now, if you take the pleural cavity and you expand the size of it, which is exactly what's happening here, if you move the parietal and visceral pleura further away from one another and you expand the size of the pleural cavity itself, there's more volume within the pleural cavity. Now, all of the gas molecules that make up the air have more room to move around, and they're not as tightly compacted And what do you have? You have a reduction in air pressure. The fact that the parietal and visceral pleura are constantly being pulled away from each other, what that does is it expands the volume of the pleural cavity. And by expanding the volume of the pleural cavity, that creates more space for the air, which is actually fluid, but it creates more space for the air, which drives down the air pressure within the pleural cavity, called intrapleural pressure. Let me give you an example. Okay, you have two cylinders, right? Here's a cylinder, here's one cylinder. I'm very bad at drawing. And here's a much larger cylinder. Okay. You take some air, and this is an air-sealed cylinder. Okay, it's airtight cylinder. Okay, and you pack some air in here. A certain amount of air. It's packed inside of this cylinder, and let's just say that there's a lot of air in there. The gas molecules are incredibly tightly compacted in here, and that creates a very high air pressure. Now you take this air and you're able then to put it into this much larger cylinder. By doing that, you're now giving the gas molecules that make up the air much more room to float around, and they're not nearly as tightly compacted. What that does is it causes the air pressure to be substantially less. By expanding the volume with the same amount of air that was in the small cylinder and then putting it into the larger cylinder, you've expanded the volume, you've given the gas molecules more room to float around, and they're not as tightly compacted, and that drives down the air pressure. That's what's happening here. Okay? That's what's happening here. Okay? What you're doing is you're pulling the parietal and visceral pleura away from one another, and you're expanding the size of the pleural cavity, giving what we will pretend are gas molecules, which is really fluid, but gas molecules, more room to float around. And thus, what that does is it drives down the air pressure. And this allows us to finally make sense of what is called intrapleural pressure. We need to talk about intrapleural pressure in relationship to intra-alveolar pressure. So there are three different air pressures we are interested in. We are interested in atmospheric air pressure, which is around 760 millimeters of mercury at sea level. We are interested in the air pressure, the pressure of the air inside of the alveoli, called intra-alveolar pressure, which also, in between breaths, is around 760 millimeters of mercury. It's exactly the same as the air pressure in the atmosphere. So in between breaths, air pressure in the atmosphere and air pressure inside of the lungs, inside of the alveoli, is exactly the same. Now, what about the last one that we're interested in, which is, for the sake of our conversation, the air pressure inside of the pleural cavity. Here in black is the pleural cavity, the space between the visceral and parietal pleura. Well, since the chest wall is always expanding, trying to expand outward, and the lungs are always trying to recoil or collapse inward, that's constantly pulling the parietal and visceral pleura away from each other, expanding the volume of the pleural cavity and driving down the pressure, we're going to call it air pressure, inside of the pleural cavity. Because of that expansion of volume of the pleural cavity, there's a reduction in the air pressure within the pleural cavity. And this is what we see then. We see that intrapleural pressure is about 4 millimeters of mercury less than either, at least in between breaths, intra-alveolar pressure or atmospheric pressure. Intrapleural pressure is around 756 on average millimeters of mercury. Intrapleural pressure is less than intra-alveolar pressure, the air pressure actually that exists inside of the lungs, specifically inside of the alveoli. And why would intrapleural pressure be less than intra-alveolar pressure? And the explanation, yet again, is fairly simple, because the pleural cavity itself is constantly expanding due to the fact that the two portions of the pleural membrane, the visceral and parietal pleura, are constantly being pulled away from each other, which is expanding the volume of the pleural cavity and driving down the pressure, the air pressure inside of the pleural cavity. And it drives down the air pressure inside of the pleural cavity so that it is less than the air pressure inside of the lungs, inside of the alveoli. There you have it. Okay. That might seem like, again, initially, it seems like, what's the relevance of this? And, well, there's an incredible relevance to this. If intrapleural pressure wasn't less than intraalveolar pressure, meaning if the air pressure in the pleural cavity wasn't less than the air pressure inside of the lungs, your lungs would collapse and you wouldn't be able to breathe. You would die. So I don't think it's possible to overstate the actual importance of this. Now, let's try to explain why that is the case. So here's what we know. Air likes to move from high pressures towards low pressures. Okay? That's always going to be the case. It's like diffusion. Molecules move from high concentrations to low concentrations. It's a fundamental concept in science. If there's a higher air pressure in one location and a lower air pressure in another location, then the air is going to move from that high pressure location towards the low pressure location. So what does this mean? It means that the air in the lungs, let's just say, in the alveoli, is constantly wanting to move towards where? The air in the pleural cavity, right? Because the air pressure in the lungs, right, intraalveolar pressure, is 760 millimeters of mercury. And what is the air pressure within the pleural cavity? It is 756. So air pressure in the lungs is 4 millimeters of mercury greater than air pressure within the pleural cavity. So what this means is that the air within the lungs, let's just say air within the lungs rather than air within the alveoli, but the air within the lungs is constantly wanting to expand outwards towards the pleural cavity. That's the point of this. The air in the lungs, where the air pressure in the lungs is 760 millimeters of mercury, that air in the lungs is constantly wanting to expand outwards and move outwards towards the pleural cavity, where the air pressure in the pleural cavity is 756 millimeters of mercury. And this is actually what keeps the lungs inflated inside of your chest. The fact that the air in your lungs is constantly trying to expand outwards towards your pleural cavity, where the air pressure is less, right? Intraalveolar pressure is greater than intrapleural pressure. So the air in the lungs is constantly trying to expand outwards towards the pleural cavity. That's what actually keeps the lungs inflated within the thoracic cavity itself. Let's look at a different image of this and try to drive the point home. So here's a different image, one that you've seen many times. But what's the air pressure inside of the lungs? Intraalveolar pressure. It's 760 millimeters of mercury. Okay. The air pressure in your lungs is 760 millimeters of mercury, the same as atmospheric pressure. Now, what's the air pressure in the pleural cavity? Here, right? it is 756. So all throughout the pleural cavity, everywhere, by the way, right? Everywhere, all throughout the pleural cavity, it is 756, 756, 756, 756 millimeters of mercury. So the air within the lungs is constantly looking to expand outwards towards the pleural cavity. And the pleural cavity encompasses basically the entire lung. You know, with a minor exception as to where the primary bronchus enters into the lung, the pleural cavity, you know, encompasses and surrounds the vast majority of the lung, right? It's everywhere. Okay? So the air in the lungs is constantly trying to expand outwards towards the pleural cavity because the air pressure is higher in the lungs than it is in the pleural cavity. The air wants to move from a high pressure to a low pressure, and that movement of air within the lungs outwards towards the pleural cavity keeps the lung actually inflated inside of the thoracic cavity. I've been saying the lungs have a natural tendency to want to collapse. They will collapse on their own. That's just what they'll do. And then you won't be able to breathe. So this pressure difference, and we'll review, this is actually what's called transpulmonary pressure. This pressure difference between intra-alveolar pressure, the air pressure in the lungs, and intrapleural pressure, the air pressure within the pleural cavity, is what keeps the lungs inflated inside of the chest wall. And I can explain this, you know, with an example, which is what's called a pneumothorax. And we can actually see how, you know, getting pierced with something or somebody getting shot would cause the lung to collapse. So imagine this. Somebody gets into a car accident, somebody gets stabbed. I know this is morbid, but something happens where an object penetrates through the chest wall. Okay? And it doesn't just penetrate through the chest wall, it also penetrates past the parietal pleura. Okay? So again, here's this sharp object coming in, and this sharp object goes through the chest wall and it penetrates past the parietal pleura. Okay. And then the object is pulled out. Okay? And now you've got a hole here. Okay? You've got a hole. You've got a hole basically between the atmosphere and the pleural cavity. What's going to happen? Okay, so you've again, something has penetrated the chest wall and it has penetrated the parietal pleura and it's created a gap between the air in the atmosphere and the air in the pleural cavity. Okay, so what is atmospheric pressure? It's 760 millimeters of mercury. What is intrapleural pressure? It's 756. Okay, well, if something has happened to create a gap or a hole between the air in the pleural cavity and the air in the atmosphere, like there's a little passageway, a gap for air here, what's going to happen? Air moves from high pressures to low pressure. So what's going to happen is atmospheric air is actually going to move through this gap, and the air is going to move into the pleural cavity. Atmospheric air will move into the pleural cavity due to this penetrating wound, which has created a hole or a gap between the air in the atmosphere and the air in the pleural cavity. We know that atmospheric air pressure is 760 millimeters of mercury. Intrapleural pressure is 756 millimeters of mercury. Air moves from high to low pressures, so the air in the atmosphere will move through that hole into the pleural cavity. And as the air moves into the pleural cavity, you're going to be getting more air into the pleural cavity. So there's going to be more gas molecules in the pleural cavity. And that's going to start driving up the air pressure in the pleural cavity. Again, as these gas molecules from the atmosphere, the air from the atmosphere, moves into the pleural cavity, you're moving more air or gas molecules into the pleural cavity. And now the gas molecules, since more are entering, are going to start becoming more compacted in the pleural cavity. And that's going to drive up the air pressure in the pleural cavity, meaning that eventually what's going to happen here is atmospheric air pressure and intrapleural pressure, air pressure, are going to equilibrate. They're going to become exactly the same. They're going to hit equilibrium. Intrapleural pressure will eventually become 760 millimeters of mercury. It will become the same as atmospheric air pressure. That's what happens when there is a penetrating wound that exposes the pleural cavity to the atmosphere. Atmospheric air, since the air pressure is higher in the atmosphere than it is in the pleural cavity, comes into the pleural cavity and drives up intrapleural pressure until they're exactly the same. And they think, well, what effect is this going to have on the lung? And the answer is, due to this penetrating force that was experienced by the body, again, be it a car accident, accidentally running into something that is sharp, that would be much less likely for that amount of impaction to occur, but it could happen if you fell off of, a ladder or something and fell onto an object. It could happen, and it does happen sometimes. Anyways, there has to be some sort of penetrating force that goes through the chest wall and penetrates into the pleural membrane, right? And creates a gap between the air in the atmosphere and the air, which is actually fluid, in the pleural cavity. And what's going to happen is, now that the pleural cavity and the atmosphere are exposed to one another, and atmospheric air pressure is greater than intrapleural pressure, the air in the atmosphere is going to come into the pleural cavity and drive up intrapleural pressure to 760 millimeters of mercury. And what about the air pressure in the lungs? It is still 760 millimeters of mercury, the same as atmospheric pressure. Now they're all exactly the same. Atmospheric pressure is 760, intra-alveolar pressure, the air pressure in the lungs, is 760, and intrapleural pressure is 760, the same as atmospheric pressure. Now what's going to happen here? Well, think about it. If intrapleural pressure is 760 and intra-alveolar pressure is 760, intrapleural pressure and intra-alveolar pressure now are exactly the same. The air pressure in the lungs and the air pressure in the pleural cavity is identical. There's no longer a gradient here. The air in the lungs no longer wants to expand outwards towards the pleural cavity, because intra-alveolar pressure, air pressure in the lungs, is the same as intrapleural pressure. There's no driving force. There's no gradient anymore. And the lungs have a natural tendency to collapse or recoil. And thus, that's exactly what happens. If you remove the pressure difference between intra-alveolar pressure and intrapleural pressure, again, something called transpulmonary pressure, which we'll look at in just a second, the lungs collapse. There's no way for the lungs to stay inflated, because the air in the lungs no longer has any driving force to expand outwards towards the pleural cavity, and thus the lungs can't stay inflated anymore because they have this natural elastic tendency to collapse, and that's exactly what happens. This is something that's called a pneumothorax, and it happens quite frequently clinically. This is why the lung collapses when something penetrates the chest wall. I think a lot of people think of the lungs as like, well, sure, if you pierce the lungs, they're just going to pop like a balloon. Like it's nothing like that. It's not really. I mean, yes, there's a pressure gradient that is, established and allowed to flow when you pop a balloon. But the reason that a balloon deflates when you pop it is entirely different than why the lungs deflate when you pop them. Why the lungs deflate when they've been pierced. It's entirely different. What's happened when you pierce the lungs and expose the pleural cavity to the atmosphere is you remove the pressure difference between the air in the lungs and the air in the pleural cavity, and that when you remove that gradient, there's no drive for the air to expand outwards in the lungs, and the lungs elastic recoil takes over and the lungs collapse. This is how your textbook depicts a pneumothorax. It's exactly what I went over. If an image like this is helpful to you, then that's great, but I'm not gonna go over the exact same thing again. So understanding the physiology of all this is not the simplest thing in the world, clearly. But once you understand the physiology of this, treating something like a pneumothorax is actually quite simple. It depends upon the severity of it, of course, but treating it is not all that complicated, right? What do you need to do? You need to reestablish the pressure gradient between the air in the lungs and the air, which is really fluid, in the pleural cavity. Currently, they're exactly the same. The elastic recoil of the lungs has taken over and they've collapsed. Okay, the person can't breathe. So what do? You need to suck the air out of the pleural cavity. So if you locate the place where the penetrating force occurred, you can stick, there are many different devices for doing this, but you can stick basically a syringe into the place where the penetration occurred. And you use the syringe to actually suck the air back out of the pleural cavity. You pull on the syringe and it extracts air from the pleural cavity itself. And that drives, of course, if you extract the air from the pleural cavity, what are you doing? You're removing air, you're removing gas molecules. And if you're removing gas molecules, then the gas molecules are less tightly compacted that are remaining. I mean, the gas molecules remaining in the pleural cavity are less tightly compacted because you've extracted a bunch of air, a bunch of gas molecules. And now the gas molecules have more air to float around. What is that? What am I saying here? If you extract air out of the pleural cavity, then you're going to drive intrapleural pressure back down. If you extract the air back out of the pleural cavity, you can drive intrapleural pressure back down to 756. And now this pressure gradient, again called transpulmonary pressure, exists again. Right? Intra-alveolar pressure, the air in the lungs is 760, the air in the pleural cavity is 756, and now the air in the lungs wants to expand outwards towards the pleural cavity again, and what you'll see is that the lung just immediately reinflates. It's a pretty amazing thing to see clinically, actually, because it's just an immediate relief from the problem. If you can extract that air from the pleural cavity and reestablish the gradient between the air in the atmosphere and the air in the air in the pleural cavity, the lungs will just immediately inflate again, and the problem will be resolved. Now, you probably find many other problems that have to be dealt with, because again, if somebody has serious damage, depending upon what the penetrating force was, certainly could be other damage that has happened to the human body that needs to be dealt with. But at least in terms of the lungs, if you can extract that air out and then close this place off, everything is pretty much back to normal. So hopefully this example of a pneumothorax enables you to better see the relationship between, or the relationship let's say this differently. Hopefully this example of a pneumothorax allows you to see why air pressure in the lungs being greater than air pressure in the pleural cavity is so important to the lungs themselves in terms of staying inflated in your chest. So one last thing, transpulmonary pressure. Okay, I've said it a million times, it's very simple. If you understand intra-alveolar pressure is air pressure in the lungs and intrapleural pressure is air pressure within the pleural cavity, then transpulmonary pressure is incredibly simple. It's just the difference between intra-alveolar pressure and intrapleural pressure. You take intra-alveolar pressure, which is typically 760 at rest, and you minus intrapleural pressure from it, which is 756, and that technically should give you 4. But it's also, this is confusing, and not something I would put on an exam, but it's always shown as a negative value because it's shown in relationship to atmospheric pressure. Don't get too worked up over that because it's quite confusing. Transpulmonary pressure is just the difference between intra-alveolar pressure and intrapleural pressure. You take intra-alveolar pressure and you minus intrapleural pressure from it and you get transpulmonary pressure. The conversation revolving around transpulmonary pressure is going to become much more important for our next lecture, which is actually the conversation finally about how air gets in and out of the lungs. We will bring the concept of transpulmonary pressure up many, many times.